So let's go ahead and get started. It's a little after noon. Welcome everyone. We are having a conversation today. This is a follow-up from some work we've been doing around transforming our communities, health equity and justice for people who use drugs. Today's conversation, I'm really excited. We're joined by our colleagues to the north, the British Columbia CoLab, and we're going to have a conversation about peer-to-peer work. I am going to be your video DJ today, for which I am basically untrained and poorly qualified, so please bear with me. A few things in terms of audio-visual notes. If you'll please mute yourself and keep your camera off, but please feel very free to use the chat for questions or comments, and we'll keep a close eye on that. As you just saw, this session is being recorded. It also can be really helpful for you if you look on your Zoom controls, you can hide the non-video participants. And that is sort of the easiest way for you to see what's going on as opposed to seeing 30 or 40 blank black squares. So what you can do is you hover over the upper right corner of a participant box and you can just click that little 3 dots and you select hide non-video participants. And that way your screen will be focused on the presentation and people whose video is on who are presenting. So I want to do a few things, and I think first and foremost, really important and in keeping with the spirit of what we're doing, I'd like to do a land recognition. And so one of the forms we do is this one, which I will read. So our teams at the University of Washington, the Alcohol and Drug Abuse Institute, are committed to addressing and improving diversity, equity, and inclusion in all of the work that we are doing. And one concrete way to move forward is to incorporate these land acknowledgements into our meetings. With the lens of cultural humility, we respectfully request your patience and teaching as we learn new practices. This is a time of growth for all of us. And specifically, we acknowledge that we are meeting virtually throughout Washington State and the Northwest on the traditional territories of hundreds of indigenous nations, with many areas covered by treaties that were signed by the United States and tribes before Washington was even a state. Our state agencies are guided by the Centennial Accord and Chapter RC 376 of our Revised Code of Washington, which respects and affirms tribal sovereignty and working with tribal governments throughout the state in government-to-government partnerships. Please join us in expressing our deepest respect and gratitude for our Indigenous neighbors. So with that, I would ask you, if you could please in the chat, just type your name and affiliation if you're comfortable doing that, so we know who you are and your organization. And we're now going to launch a brief live poll about who is here today. We really appreciate you filling that out. And you'll also, please select all that apply. We recognize that people have multiple identities, and we would ask you to please express yourself however you'd like to. So please go ahead and fill out the poll. And just take about 10 more seconds. If you have not filled out the poll, please do. And I'll read the poll results in just a moment. So I'm going to go ahead and end polling. Looks like most people have done that. So let me share those results with everybody here. So what we have here, people self-identifying as people who have lived experience, is about 16% of folks. People who identify as behavioral health primary care provider administrator is about 1 in 5. Care manager, navigator, or peer support, kind of a big group of folks, that's 11% of people. A quarter of folks identify as working with a harm reduction program, which is wonderful, welcome. We do not have anybody who is self-identifying as tribal or urban Indian. We have 1 person from criminal legal system, welcome to you. We have about a quarter of folks who are identifying as academic researcher or evaluator, which is wonderful. I'll mention in a moment why we made sure to involve those people as well. We do not have anybody who's identifying as a first responder, and we have 1 person identifying housing, homeless services, and then a lot of people entered additional things in the chat box, which I will not read, but which you can see. So I hope that you'll take a look at those. And this is exactly what we really hope for, is to get a really diverse group of folks as we're going to hear from our colleagues, this is a group enterprise that needs people from multiple different perspectives working collaboratively. So I'm heartened to see the diverse people who are participating today. So just a little bit of quick background in terms of implementing co-design and partnerships in our work. As someone who has worked with people who use substances, as I know that I personally have an enormous amount of growth to do. And I imagine that most of us think of ourselves, and hopefully we are, very empathetic people. And I think what I'm coming to realize is that empathy is necessary, but not sufficient. Where we really need to move to is power sharing. And that is very different and much more complicated. So we are doing this work in that spirit with a recognition that to really improve individual and public health, it's gonna take creating good services in partnership with those who are actually going to be taking advantage or not of those services, and being working with them truly hand in hand and as co-equals. And what I'm really excited about in learning about the BC CoLab is they've put a lot of thought into developing that process. They're at least a few years ahead of us, if not maybe a few decades. And so I very humbly invite them in and excited to learn from them. So I think with that, I will stop my piece and hand this over, and I will ask the folks to please introduce yourselves. You'll do a far better job than I will. So if you would please introduce yourselves as you're speaking, that would be wonderful. Thank you.
Hi, everybody. This is Bernie Pauly. I'm one of the people that's going to be presenting today, and I'm just going to share my screen. That's okay. Are you seeing a screen?
Yes, I can see it.
Okay, great. For some reason, the poll is still showing on my screen.
Or do you have to click the X in the upper right?
Okay, my apologies. How come it's not showing up there? Okay. Just one second. Here we go. Thanks. It's always humbling to be on Zoom. So I'm one of the academic partners that's part of CoLab, which stands for Community Collaborative Laboratory on Substance Use Research and Action. And we're going to do a really collaborative presentation today about how you move from working with people with lived experience as participants to partnerships in research and practice. And in some ways, what we wanted to do is share with you a bit of history, because CoLab has really only been funded. We've only been funded for almost approximately a year now. And we thought we'd share with you a little bit of what has led up to, you know, kind of how we've approached and structured CoLab in terms of our partnerships with people with lived and living experience, as well as community organizations and public health and other academic researchers. Jane Buxton was going to be with us today, but she unfortunately had an emergency this morning. So we had a few last minute changes, and that's kind of part of the amazing thing about being part of a partnership, you know, being able to accommodate and work together and take a lead and when you need to lead and follow when you need to follow. Also with us is, I'm hoping, Tracy Scott. She's an experiential worker with Rain City Housing, and she's an experiential research associate on one of our projects called P2P. Tracy, are you there?
Hi, I'm here. I'm eating. I'm sorry. I'm sorry I was late. I made my lunch. I looked down and I was like, oh crap.
Well, we're very happy you're here, and you can relax and eat your lunch, because I'm going to do Jane's part at the beginning, and then my part, and then we'll introduce P2P. And also with us is Erica Thompson. She's the executive director of the BC Yukon Association of Drug War Survivors and a partner on CoLab and our risk mitigation guidance evaluation. Erica, are you there? Do you want to say hi? Tracy may still be joining. I know she was, or sorry, not Tracy's here, but Erica may still be joining because she was, I was in communication with her this morning. So I'm going to get started with a bit of background before we jump into some of our specific projects. About a decade ago, actually, in British Columbia, Vandu, which is a drug user organization in Vancouver, one of the oldest drug user organizations in the world, actually, I think. Although I'm sure there are others who I don't know the history. It's definitely one of the oldest in Canada. And worked together with Jane and others at the BC Center, or BC Center for Disease Control. And they conducted workshops across the country to find out what were the priorities for improving health and social services for people with people who use drugs. And you can see on the screen there that there were 8 priorities documented. One was to improve interactions with health professionals. And there are many projects, collaborative projects that have focused on this, but I'm just going to focus on one that I've been involved in. And then promote access to a range of housing options, improve treatment by police, ensure harm reduction best practices are followed everywhere. And I'm going to highlight a project that Jane and I and many others were involved in. Connect with illicit drinkers. I'm going to highlight some current work there. Improve social assistance, support user-run organizations. And Erica is here from BC, when she arrives from BC Yukon Drug War Survivors, I think is going to be able to talk to that just a little bit more. And then engage with, encourage allies. So these were the priorities that were identified through this traveling caravan that went across the province in 2010. And you know, it's really interesting for me as a researcher who was around at that time and doing work to reflect on them a decade later and see, at least in my perspective, that they're still highly relevant set of priorities. And today to be able to share with you some of the work that's been done in those areas. Probably about a year and a bit ago at the beginning of some calls by our National Funding Institute to really try to bring forward what were some responses to the current overdose or the current illicit drug poisoning epidemic that's sweeping our country. So we were funded to do an equity-oriented review of responses to overdose and stigma. And I want to pull out here just one of the findings from that I think is really important to this work. You know, the social networks, which we understand in public health as part of a ecological model or approach, are really important and protective for health, and we know that. And so in our review, what emerged is that organizations by and for people who use drugs, peer-to-peer networks of people who use drugs, families and communities are really important to protecting and mitigating harms of drug use and overdose. And those are should be central to an equity-oriented response. Our review also highlighted that it's really important to pay attention to women, to sex and gender considerations, and racialized groups, because often their voices and their involvement is less less prominent in our responses. And so if we sort of think about that, you know, we can sort of think about how are we going to actually do this? How are we going to move from this idea that people are participants in research, or they're users of programs, service users, I guess might be the term, to actually partners in programs as well as in research. And obviously I'm a researcher, and so I am, you know, think about it from kind of that perspective. But you can see here, you know, this takes a couple of different sort of ladders of participation that have been around for a while, and goes from kind of the idea of people being recipients or participants in research to, you know, tokenism, where we sort of inform people, or maybe we have someone that is in an advisory or consultation role, to something that's organizationally initiated, where, you know, the organization says, oh, let's have somebody sit on our board or something like that, or we hire, you know, some peer workers. And then we go to the next levels, which are really about moving towards partnership, where we're building peer networks, where that partnership is shared and decision making. And it's really, the work is critically done in partnerships with strong groups and networks and organization of people who use drugs. And I hope as we go through this, some of the projects that we're going to share will illustrate that. You'll recall, I'll just mention this one project because it relates to that priority about connecting with illicit drinkers. My colleagues at the Canadian Institute for Substance Use Research, where I'm located on the traditional territories of the Lekwungen speaking people, and acknowledge that I'm a settler there as well. I should have mentioned that at the beginning. But we, on this large program of research, we're very fortunate that out of that caravan was a group called the Eastside Illicit Drinkers for Education was formed. And that group is a partner in the Canadian Managed Alcohol Program research. And we have a coordinator who works part-time with them and part-time with us. And I would say she is absolutely central to facilitating the partnership and work we do together. Just to give you an example, you can see on the screen there, it says download our safer drinking tips during COVID-19. That was a little infographic that we developed together with Edge that they distributed throughout the downtown east side, and it was distributed actually all across the country around how people could stay safe from COVID, particularly for people who were heavy users of alcohol. And so that's just kind of one example from a study. This study's been, we're in about, I think, year 9. And we've partnered together on many aspects of the research with Edge based on their priorities. Here's a second project that I'll just briefly share. It was actually a project that was initiated, interestingly, by our health region because of their interest in promoting patient-oriented research. And we had a lot of support from the patient-oriented research unit. But the reason I want to show you this one is that the way that we structured this work was that we put at the center of it 2 organizations, peer-run organizations, Solid Outreach in Victoria and Umbrella, which is also a peer-run organization, both in Victoria, as the core team. And they were the community researchers and collaborated with the academic researchers to implement the study. And so those groups on the outside became the advisors to them, which is a complete shifting of the power in the research. The focus of the research was around safety and primary care for people who use drugs. You can see here our research team, and that most of the people at the table there are community researchers. And there were more community researchers and people who were people with lived experience than there were academic researchers on the core team. We used a methodology that was implemented by the community researchers called concept mapping, which starts with a brainstorming question. Ours was, I would feel safe going to the doctor if. So you can see how this links to the priority identified in the caravan in 2010 about improving relations with healthcare professionals. And then that through a structured process results in a model of safe primary care. And one of the things in this project that was really important and a huge learning, I think, always, is that you can't simply do the research, you have to do action. And I know later, I think, if Erica is able to join us, she'll talk about the importance of the advocacy. So we created this little postcard together, and those 8 little sort of colored blobs of paint contain the 8 clusters that emerge from the concept mapping. And it highlights what people told us was important for safe primary care. And then these postcards were distributed throughout, our region, throughout the province as well. It's interesting, the other day, I just happened to be doing a focus group in one of our new hotel settings with a member of Solid, and I noticed that there were some postcards laying around in the room, and they said, oh yeah, we just did a training here. And so we had brought in some of the postcards. They had been training some of the housing staff, and I could tell a lot of stories about these postcards and where they show up and what they're doing, but they have even been used by individuals to advocate for themselves, to say, hey, this is how I expect to be treated in my care. We did a lot of other things in this project to move towards action. We did a bulletin, we developed a workshop for primary care providers, we've done a podcast, and we created these animations, there's 8 of them, around illustrating the findings of the study that are part of the workshop. I don't know, whoops, sorry. It just moved a little too quick. I don't know if I'm going to be able, we've had trouble getting the sound going. Are you hearing sound?
No. Sorry, Bernie, we don't hear sound.
We
Okay.
could see the video, but not the sound.
Oh, well, you're missing some mostly sound effects. But I'll just let you watch the illustration here. You'd hear feet walking. There's no talking. I apologize you couldn't hear the sound. Most of it's sound effects of feet walking and great little sounds about kind of how do we, one of our clusters was be a champion for advocacy. And so this just highlights how we used animations to get across some of the key points. And the animations were all led and developed by our community researchers on the project, and they're part of the workshop that we do. If Jane were here, she would, a very important, I think, piece of work that happened, and this happened a number of years ago, was the Peer Engagement and Evaluation Project, or PEEP, which was a project to basically identify some best practice guidelines for health authorities and regions. And so it was not so much aimed at building strong peer networks, which we know is foundational to this work, or strong peer organizations, but it was about how do we get health authorities ready for employing, engaging, and working with people of lived experience. And some of the outcomes of that project, and it's important to include, is the peer engagement principles and best practices, which was a guide for health authorities and paying peers in community-based work. So we included this project here because I think it shows the work that needs to be done on all aspects. Some of the biggest work is for me in my academic institution to better ensure that my projects and our organizations are able to do work in a good way, and how do I contribute to supporting community researchers in the projects, and then they lead the projects. A very important development that happened for us in British Columbia that has really propelled peer engagement and work was the declaration of the state of emergency related to overdoses in 2016, which resulted in a ministerial order around overdose prevention, or OPS, and that peer engagement and work is recognized as best practice in harm reduction, but also in BC harm reduction policy. So we actually have harm reduction policy in BC, and we have at the forefront the importance of peer engagement. And so overdose prevention sites were developed directly by and for people with lived experience. And there's been quite a number of research projects, including ones that we've done where we've worked collaboratively to identify some of the impacts and the priorities, and also some of the challenges. Peers are often not valued in this work. Their contributions go unrecognized. Some of the issues related to poor pay, inconsistent and ongoing work opportunities are some of the challenges. So we identified that it was really important to design peer-led support interventions for experiential workers in BC who were providing services in overdose response environments. So Jane led the peer-to-peer project. We co-led it with two organizations, Solid Victoria, Rain City, Vancouver, Maple Ridge, and Coquitlam. I'm just gonna say a couple more comments, and then I'm gonna turn it over to Tracy, who's gonna tell you a lot more about it in a minute or two. So this was a mixed methods, a multiple phase participatory community action project. There were 8 focus groups conducted between November 18, March 2019 to talk to people who worked in overdose prevention sites. One of our members designed a logo for the project called the Rose because it symbolizes the initiative, the Rose Initiative. That was the intervention that we developed. And ROSE stands for recognition, organizational support, skill development for everyone. And I'm now going to turn it over to Tracy, who's going to tell you about the ROSE model and some of the things that we've been doing.
Thank you.
Getting it up and going.
baby girl. I love you. Hey guys. Hey, good. Yeah. My name is Denise Edwards, and I'm known as Grandma Coquitlam, Ma, Mom, or Grandma. I answer to all of them, and I'm proud to be a peer worker.
I became a peer worker just over 3 years ago. As a person, you know, that spent his life in prison and spent his life doing drugs, you know, I thought, well, what am I going to do for employment? Well, no one's going to hire me. And then this guy wants to hire me. And I said, well, what do you do? He said, we work with street people. And I thought, well, that's something I really know.
Maple Ridge treats their homeless and their drug addicts like they're garbage, like they don't belong here. My grandmother taught me that you say hello to the drunk on the corner, the exact same amount of respect as you say hello to the jerk in 30s Gucci suit.
With the fentanyl crisis going on, I had a lot of really, really close, good friends that have died, and it's hit me really hard. Like, I just want it to end. You know, I want to be able to be part of the, you know, solution, not so much to part of the problem. When I first started working here, I had an overdose. I think my first 20 minutes of work, I got thrown right into it. It was right in my training shift. I had previous experience with CPR and stuff like that, so the only difference was actually giving the Narcan as well. Most overdoses, we get to them before their heart actually stops. So when you're giving CPR, you're not having to give chest compressions. You just have to give air, basically, right? You got to keep the brain alive.
In Maple Ridge, we don't have safe injection sites or anything, so we do what they call peer witnessing. Example, in my building here, if somebody's going to be home alone and using, lots of times they'll let me know, so I can go up and check on them, and you know, I'll stay until I know you're safe, and then I'll leave, right? To me, it feels good to make sure that there's one less person dying, right?
Who is that?
Michael Perry and
Come on in.
Hey.
What's up, guys?
Both of them. Mike needs
Sounds
to
good.
because I need to help you guys with this message. I gotta work.
Okay, I can
Tim,
help you. Tim, where are you?
You coming in, aren't you?
Don't be so shy. Come on in. Here, honey. Okay, I want you to sit down over there, and I'll help you with this.
Here, grab the green bait jacket. Oh, what are you doing today?
You can sit on my bed if you want. I'll let you sit on there for now. Yeah, right there's a good one.
Oh, yeah, I've overdosed 3 times and got Narcan. The first thing I did when I was told that I was Narcan was went over and gave the guy a hug. Man, thanks a lot, you know. I didn't want to die, right?
Yeah, Dan's good. We're always stocked up with stuff. Trying to think if there's anything I missed. We got the alcohol, we got the rigs, we got hookers, 2 types of Narcan. Saving lives. You know, when someone comes out of it, you just feel elated. It's like, did a good job, eh? Shake the guy's hand, he smiles at you. Or sometimes he'll just insult you. Yeah, so that cost $30. You didn't move $30 on me. But I know that's him in that moment, because I know next day he'll come over and thank me for, you know, for helping him out, eh? And that's the best. Someone just says thank you.
The biggest challenge is the stigma. People have this idea that any addict is a useless piece of poo-poo. And that's just not true.
I've been actively dealing with an overdose and been told to stand back because I don't know what I'm doing and wait for the paramedics. And meanwhile, this person is dying. And they're trying to tell me I can't wait for somebody that's more qualified, even though I've done, you know, 70 or 80 overdoses at that point. 99% of the time, I've got the person up and coherent before the ambulance even gets there.
I'm a first responder. I'm one that's there firsthand. I've saved 72 lives up to date. I haven't lost one yet, and I don't plan on it.
And I understand homelessness. I understand living on the street. I mean, I lived on the street for 5 years. There's a lot of fear, right? A lot of fear based around people with addictions. Street people walk by and they look at them and they're afraid of them, eh? They think they're, I don't know what they think, but they forget they're human beings.
I'm in trouble. I'm addicted to this habit of never socializing. relaxing, only simply memorizing the corporate.
Her name was Mariah. She went by the name Credence because growing up, Credence Clearwater was a band that she really liked when she was a kid. So yeah, she passed away in 2018 from an opioid overdose. I think that's what made me fight even more for people, is that I don't want any other parent to have to go through that. A parent should not have to bury their child. No, never. Being a drug user and working in the field I work, it doesn't affect my job. It doesn't affect the way I work. In actuality, because I'm an addict, it makes it easier for me to be able to help the people, because it doesn't matter how many years you go to college, you'll never have the one thing, and that's lived experience. If you haven't been there, you can't relate. And that's what makes it so much easier for people to come and talk to me, because I understand, I get it.
We can go in and talk to them and they'll actually listen to us. We're still in their community and we're basically them, just doing a job.
This is our memorial garden where all our loved ones are. We haven't lost that many, but we've lost a few really dear, close friends, and we consider them our family. Stan the man was an outreach worker, the best outreach worker there ever was. He was my outreach worker. He's the one who inspired me to get into being a peer, into helping people. Stan the man relapsed. And he was all alone. I don't know, of all people, he should have known not to use alone, but he was embarrassed. I know he was.
We walk the streets day in and day out. We struggle to survive because that's what it's all about. The city only wants to throw us away, but we're human, have feelings, so why can't we stay? We take the fall for all the wrong. We have rights and we stand strong. Men, women, and children, we're sick and we're old. We need to be heard so we won't fold.
These are my reminders. Hey, people that have lived the best they could with the addictions that they had. Tears of sadness, tears of joy. Yeah, they're all in a better place. And I'll always remember the conversations we had, people that they helped, and wherever they are, they're always still helping people.
Rights with equality for all. Together we stand, united we fall. We open our hearts and minds to see there's no difference between you and me, because we're the family of humanity.
Turn from solid, coming in.
The peer program is pretty amazing because it gives people from my background an opportunity to be a member of society and make things better. Since I started working this job, I've actually gotten a reason to get up in the morning again.
When I go out on the street, I see people for people. Just trying my best to be a human being. That's it. There's no big glamorous thing for me. It's just, I want to help people because people help me.
Accomplishing more than the eye can see, handing out supplies, you're witnessing, ensuring everyone's safe as can be. We have saved lives each and every day. First responders, seriously, it's not a game we play. We're there to confide in, to advocate, to fight all our time. Here's that patience, understanding, and right. Wanting to have the blessings, keeping people alive. We carry much on our shoulders, out there on the scene, uncalled day and night, wanting no more lives lost in this harsh war. Decriminalizing and safe supply would make it right. Here's our patience, understanding and pride, wanting to help the blessings keeping people alive.
Okay. Okay. I'm just gonna move. We could have probably spent the whole time on that project because the amount of resources that we've created based on the opportunity to work in partnership. And I just want to highlight before I turn it over to a current project and talk and turn it over to Erica in a minute or two, is that things have changed dramatically with COVID-19. And we're finding people had a lot of reduced access to services, drugs were more toxic, more workload for peers. So we've continued through P2P to develop COVID-specific resources for responding to overdoses, which you can find on the website, including some videos and so on. When Caleb introduced this, he introduced it as CoLab. And like I said, CoLab's about a year old. We've been so honored and privileged to work with so many partners, with drug user organizations across the province, networks of peers, as well as our community partners and health authority partners. And we've all come together into this, what's called CoLab. And in CoLab, how we think about community-based participatory research builds on some pretty well-known approaches, starting with an advisory model, which we've talked about, an employment model, a partnership model, and then added on the importance of advocacy, which was added as a role in CoLab. One of our main projects right now is related to the rollout of a safer supply of substances and a mixed methods project that we're undertaking to evaluate the effectiveness. We're using a model that takes in all of these roles. It's in partnership with BC Yukon Association of Drug War Survivors and PEEP, and Erica is here, and I'm gonna turn it over to Erica to talk about BC Yukon and their roles. Over to you, Erica.
Hi, I'm just gonna move my vehicle because I was en route to the office here, and I'm right by a chipper, and so it'll be really loud, so just bear with me here so I can move, hopefully, away from that sound. Right here, by the water, okay. All right. Hello, everyone. Can you hear me okay?
I can hear you beautifully, Erica. Thank you. Whoops.
All right. My name is Erica Thompson, and I am the Executive Director of the Yukon Association of War Survivors. This is a provincial group, just a little history on us. I had been a of an Abbotsford chapter for 8 years, closer to a decade. And I had been, using substances for a very long time. I was a mother who uses substances, and I had been, put through institutions and treatment and conflict with the law, and all of the intersectionalities that can happen to someone who's involved with substances, especially in the context of illegal or illicit drugs. And so a lot of my experience, of course, was very punitive. It was the only models really of care that we had available for me that I was ever really offered at the time was, an abstinent-based and 12-step community, which, it had, been useful in my life to a certain extent, I would say. And I mean, at the point I was just willing to, try anything, because I didn't really understand my relationship with substances, because it wasn't something we really talked about, right? So as I've, grown, I've realized that it was not necessarily all on me, because they like to put it on the person a lot, and they as in, healthcare systems or counselors or you name it, criminal justice judges, all of it, that somehow we're inherently broken or bad or broken. So it's this the tug of war between a criminal justice system and a medical model that inherently sick, inherently broken, inherently bad, deviant. And so what I started to, as I grew and I started to leave more of a community of abstinence, because there were certain things that didn't sit right with me in that community. And I definitely utilized all the wonderful things about that program, and a lot of the rest of it I kind of had to leave behind, or because I did a lot of critical analysis on it. And what I found was I needed a community of support, but I needed it to be beyond this type of very, abstinence or die attitude. And I didn't think that served us well. And so I ended up coming across, I worked right. I dove into harm reduction right away over 10 years ago, and I always identified as a lived experience or peer worker, even though I'd been told by some I was a service provider now, and all of these things. But yet, at my heart, I didn't have a degree. I didn't have formal education. All of my knowledge and abilities to work with people who use drugs had come from my own experience, and so. I worked at this amazing place, a drop-in center for street-involved women, and I worked with it. We were actually funded to have one of the first peer teams. Now, this is over 10 years ago, and many who which have been involved in what you're hearing today. The PEEPS program. I remember when Jane came down, and she came down and visited me at the Warm Zone and asked me, around some of the networks of people who use drugs and folks that I had known and been in community with, and many of them had come from this group that would hold a meeting once a week in downtown Abbotsford, and they were called the Abbotsford chapter of Drug War Survivors. And so I went to these meetings, and I found that this was, we weren't looking at the person anymore. We were challenging systems, and we were looking through a lens of human rights and social justice. And for me, it was like this relief of, there was so much more harm that was not like my personal relationship with drugs. There was so much more that were coming from, systems and structures and social stigma and discrimination, and that, when I had my child removed, which was one of the most devastating, most violent acts done to me, and through this, it was never on my parenting. It was because I had tested positive for substances through a hair follicle test, and that was enough to take my child, and that rocked me, right? And so I had always been like, the self stigma. It wouldn't matter how bad people would talk about me, and and my being a mother and using drugs. My dialogue was so much worse. And so when I came into these rooms, that wasn't about making me feel bad. It was about that the systems had, and policy had played a large part of how these violent acts could be enacted upon me and other parents and women and our Indigenous population that was, you know, disproportionately represented across the board, whether it be burden of health or criminalization or child apprehension and foster care. And so when you're able to take that critical analysis and take a look at these systems and structures, it allowed me to feel better about myself. Now, it doesn't mean I'm not accountable. It means that it's not all about me being broken or bad or deviant, and that I always just envision, wouldn't it be a beautiful world if we were able to leave all that behind and just focus on a person's relationship with their substances if it was causing, you know, if they identified it was causing them harm. And for those that it didn't, just to be there and supportive for access to you know, the human rights that we have to access health and housing and employment and all of these things that policy had created a barrier to. And so I fell in love with that group and that community and that lens. And I continued on my way. And so going back to, I'm sitting in my office and Jane Buxton comes in, and it was when they were starting to work on the PEEPS program, and she had a peer team, like I said, one of the first peer teams ever developed. And we were out in the Fraser Valley, and it was through a Stop HIV program that we were able to be funded through the Health Authority. And we had a team of experts, and we were our expertise was anything from HIV to hepatitis C to sex work to mothering and substance use, injection, and conflict with the law and foster care. And we had two Indigenous experts that were on the team, so colonization and the effects of, and you know, and we were able to work together and have this amazing set of expertise amongst our group. And Jane wanted to poach. I always joke about that, poach our expertise. No, but she genuinely, you know, was working on this and was looking for some people. So I was able to provide an opportunity to one of the peer experts, Sherry, and she went off to work on PEEPS, and she still works with me, but it was part of her work. I gave absolute, you know, gratitude that she was going to be able to have some capacity building through working with Jane in this program. And then I remember when again, and I think, Bernie, that's the first time I think you met me or you were there, when it was the P2P. And long before that, when it was in the beginnings, Jane had invited me, and I had made, you know, she's like, you know, who would you recommend? And of course, you know, I recommend a lot, but I always thought that Rain City and their peer program, or not program, I shouldn't call that, but their expertise, their peer experts that were involved in the work that they were doing. I definitely said for a service model, I would go with Rain City and Maple Ridge, because I was familiar with Tracy and her team out there, and thought they were doing amazing work. And also for an organized drug user group. And so that's kind of how, you know, because I had gone to this meeting once a week for Abbotsford, I started to develop relationships with other community networks that were these organized drug user groups that really took on this. They weren't looking at necessarily delivering services, and they weren't like wanting to fix people. We don't fix people, we fix systems. And then people fix themselves if they need fixing, you know, if they identify that they need to be fixed. And many don't. And that many just needed their basic human rights met, and to have, you know, equitable access to healthcare and employment and housing and all the things that I talked about that people, you know, need to thrive, or at least to survive. And so I mentioned a group, Solid, that I knew, and, you know, because of my networks and being part of a provincial group, because I got involved with the provincial group, BC Yukon Association of Drug War Survivors, because they were focused in on Abbotsford, because we were the third highest Hep C rate back, and this wasn't very long ago, because we had a harm reduction bylaw. So this bylaw basically restricted any harm reduction services from taking place in Abbotsford. And what do you know? Do you go figure? We would have the third highest rates in all of BC, and it was directly correlated, of course, with not having access to supplies. So Jane, I introduced her to, I recommended Solid, and off she went again. But going back to BC Yukon and in Abbotsford, and at that time, about 10 years ago, we marched on City Hall, and we dumped about 15,000 used syringes on the steps, because there was no place to put them. We were not able to receive them, but there were some services, well, one in particular where I worked, that continued to break the law and give out harm reduction supplies, and hoping we would get arrested, because therefore we would have a chance to take them to court and we'd win, because this is a health issue. And to put a bylaw up and create this horrific numbers of hepatitis C on folks, on people who use drugs because they couldn't access essential tools and health services to reduce the infection, or the chance of being being at risk for hepatitis C and HIV. So doing that action, that political action, that social movement, that social justice, we were able to change that bylaw, and now there are many services in Abbotsford and other areas. So these are the things that, for me, it was like, this is where I need to be, because it's very personal for people to work on self and to identify whether they want to change. And I found that what I knew for sure needed changing was the system. So by being part of these groups, and I do get emotional about it, because it's when I look at Tracy and I look at people doing the work, and I'm watching this video and I see these are women and men and youth that I have watched, or had the honor of working with, or presenting with, or mentoring, and creating space, and being able to now be a part of BC Yukon, where for 10 years we were working and getting little pieces of money to put on an AGM, and or have stipends for meetings of $5, and crowded little rooms, and to talk about our basic human rights, and the actions that could make life better for people who use drugs. And so we'd never had sustainable funding, and sadly, it took the overdose crisis, the prohibition crisis is what I like to call it now, because this is a result of prohibition. What you're seeing now with the toxic drug supply, and people dying at this rate is really due to prohibition. And so when I'm able now to be in this position, and I went from working frontline and working with women for 8 years, and then I went 2 years into the health authority. So Fraser Health was the first health authority to create a peer position that was in leadership. So there were some peer positions amongst VCH, but I actually was at a leadership level where I could influence policy for contracts, and part of that was getting money to drug user groups, and we were able to fund Abbotsford, almost $200,000, and they still have that funding today for their group to continue the work in Abbotsford, and now OERC and the ministry had created a $1 million, opened up $1 million, which is not much when you look at the work that we do as a provincial network. But it was way better than a little $5,000 Hep C grant that we would write and get the money for. And Ann Livingston, she would be chasing up the BC CDC and folks like Jane and Alexis Crouchy and such to get these small little grants. And I would be writing proposals off the side of my desk to get these small little grants, but now have $1 million that we seed fund. And we have 14 groups right now across BC that are now funded through the seed funding to come together and find a place to meet, because the places are one of the hardest is to get space, public space. I mean, we can barely find space on the street or sitting down. If there's more than 3 of us, you know, we're being moved along, you know, and so it was really important that we were able to help people find space and pay rent, because a lot of the grants or a lot of funding opportunities didn't cover rent. And we all know how expensive rent can be. And so we were able to take some of that money and put towards rent and put towards honorarium and put towards a coordinator. And so we're not really funding services, we're funding the basic needs of a foundation, because any group that wants to get into services, we highly recommend that you have a community of support around you, that not a lot of people know how to support peers doing this work in a safe way, or it's new for a lot of funders or NGOs or service providers that want to include peers, and some of it can verge on exploitation, for sure tokenism, and what we're looking for is a strength-based. And so, you know, through these groups, when you have a strong foundation that's built on a democratic, you know, governance and consensus-based decision-making in that governance, that you have a strong foundation and a community of support, because these are just not groups, they're your community for many of us, they're a family for many of us. And so to be able to be here in this position as an executive director, who would have thought, you know, a long time ago when I was out there and you know, desperately lost in finding my identity back and who I was, that this was where I would end up, and just very grateful to be part of this, you know, liberation of drug users and this family and community of support, that no matter what, whether you're not using or you're using, if you identify as someone who, as a substance user or someone with lived living experience, we're here. And we very much want to, we know what it's like to have the self-stigma. We know what it's like to find recovery and relapse and feel the guilt and shame and use alone because of that. And now we can't afford to do that because we die. And so when we wanted to create that space that anybody could come and be authentic, and that it was okay, and that we were going to make the changes that would improve your life, and you can work on your wellness, but we'll get rid of the extra harms and violence that we see every day that impact us, over a policy that says no to drugs, and that this is bad and wrong, and we can take your children, and we can take your job, we can take your reputation, we can take your home, we can take your assets, and we can take your life. And that's what we see today. So I'm really grateful that I get to be a part of this, and creating solutions and more effective responses during this time, and which leads us to, you know, the nothing about us without us, which leads me to, you know, the research that I'm grateful to be working on with Bernie. So when I'll take a breath here for a moment, and then I'll get into a little bit about the research. Now you know who we are. We are a provincial group of groups. We seed fund, and tell you a little bit about what our contribution is. And is it okay if I take a moment here if anybody has any questions really quick, and then I'll get into the research? No?
If anybody has, this is Caleb. If anybody has questions, please feel free to put them in a chat box and we'll share them with Erica. Really appreciate what you're sharing, Erica. And we probably should take about 5 or 10 more minutes, if that works for you. This is great. Thank you.
All right. So I'll get into it then. We of course have this funding for, you know, seed funding drug user organizations across BC, and we we had also a few CAI grants along the way, and one of them was, of course, a hotline number and the wristbands that you see there, which we wanted to make sure that when I talked about the intersectionalities before around system intersectionality, we thought this would be a great place, a great idea to get this hotline up and running, so that no matter where you were in BC, if you were if you were kicked out of a treatment center, let's say, or released from prison, or from remand, or even courts, that you could be, leaving a merge after an overdose and having no supports or connection, that at the very least, it would be great if we could get these wristbands out. And so if you were leaving, you would get a wristband and would have a number on there, and you could phone it, because, if you're planning on using, or if you're sick because you've been detained for 3 days over a long weekend in a city cell, that, or if you went to treatment in another community, and you didn't know anyone, that you'd be able to pick up the phone and you'd be able to land safely somewhere. So that somewhere in BC there would be a drug user group close to you, and if not, we would also have our connections with our vast experiences with and allies that we have, connections to allies and services across BC, and to utilize those relationships for people to have a safe place, or a safe landing, or safe connection, in order to, like I said, to be authentic. And if people are going to use, they're going to be able to do it safely and with peer support. And so that we know, many of us know that we can do a lot of things that systems may not be able to, and there's a lot of red tape, and for different reasons, liability is usually what I hear. For many of us, we know when people used to say, what was the commonality, what was the common thing about the hidden drug users, and it was like, well, they're drug dealer. And so for many of us, we were able to work in these networks and share information that's vital, and connect with people that may be the only people connecting with people who use alone or indoors. And so as all of this, the work we're doing in our networks there, when the prescribing guidelines came up with COVID, with COVID, changed a lot of things, and one of those was that they were going to work on new prescribing guidelines for people, in order to stay, listen to Bonnie Henry and do, stay at home if you have a home, and limit your contact with folks, and going out and about. And one of the big problems is, if you are dependent on substances, physically, mentally, or otherwise, that was going to have a hard time staying at home. And so this prescribing was like very close to what we were hoping to be the safe supply, and not necessarily the way we would hope to have it. However, we'll utilize this. But what we thought for sure was that it didn't seem to be as easy. Would it be as easy as it was kind of laid out at first? And so we quickly, our hotline number first was a safe supply number for this prescribing, this new prescribing. And so folks were phoning, and just some of the things that they were going through was unbelievable. Well, it's believable if you've been in this work as long as I have, like, to know what to expect. And there was everything from, pharmacists pushing back because, now they wouldn't be receiving their dispensing fee, and they wanted to limit giving carries, because in the guideline you could get, I think, 21 or 23 days, up to 23 days of your medication that you needed. And, so there was all sorts of still stigma and discrimination, and doctors not stepping up to prescribe, because, let's be honest, they've been taught not to give drugs to drug users. And so now that we're, in this awful mess, where our messaging has been, don't use alone, to stay home alone. If you don't have anybody with you, you're home alone. And so it was really mixed up messaging. So we put this hotline up for advocacy and support, because that's what we do. We do advocacy, support, and education for people who use drugs. And we got, as we were going along, it was definitely needed to be evaluated. And so there, Bernie was involved in some other evaluation with us, and reached out and said, like, we need to do something about this. We need to take a look here, because this, you know, cannot continue as it is, and we need to be able to show that this isn't working, or it's causing more harm, more barriers and such. And so that's where we actually reached out and got this project going, and have been a part of this, and will continue to be a partner in this as we move along. As I said, we believe, you know, that if we're going to create effective responses or services and communities, that we must be involved in order to do so. It would be extremely ignorant and negligent otherwise. So that's where we're at. As you can see from the pictures there, that is our hotline, and these are our wristbands, and hopefully we'll be coming to a place near you. I'm talking to the States, aren't I?
You are, Erica. That was amazing, Erica. Oh my gosh, the history. I'm sure, like, the history of understanding the development of the drug user organizations, the investments that you fought hard for, that are being made, and then to recognize, and this is the you know, for me, because I'm a researcher, Erica identified that there was a need for research, and reached out, and that's really why my colleagues Karen and I and CoLab are all part of this, was because we were invited to participate in research, and that for me probably is a theme through all of those other projects that I shared with you, and the building of relationships and contributing to this work is important. So,
and we did with Bernie, and thank you for mentioning it, because see, every time, if I share from the heart, I don't have notes, so every time we do this, it'll be different a little bit, you know. And you asked me to do a little bit more of the background, but I really wanted to say how we look at research as what can research do for us. You know, it's great, you know, to be published and all that and wonderful stuff, and to work on this, but what can research really do? And so it's really important to understand. And when she showed the model before with what community-based research, you know, why we do it, there's a huge part for us. It's advocacy. What can your research do for us to leverage it and use it in a place where we can show that this is, you know, causing harm or barriers, or shift policy, because we have the research that backs us. Harm reduction is probably one of the most, you know, researched issues out there, and so that this was something that we wanted to leverage and make sure that if we were involved in research, that it was somehow going to serve a purpose for us and make things better for us. So I just wanted to add to that.
That's awesome, and I think that's a perfect ending. Thanks to Erica and Tracy so much for contributing. I know we've gone a little bit over time. I think we were all worried that without Jane, we might we might have less to present. So over to you, Caleb.
Okay, great. Thank you very, very much. Appreciate all of you, Tracy and Erica and Bernie, for sharing your expertise. And my internet's a little bad, I can tell, but I do want to read off a couple of questions, at least one question I have here. My colleague Karen Lizzie with the Cowlitz Tribe wrote in and asked, many substance use disorder professionals, those are our licensed addiction counselors in Washington State, many substance use disorder professionals have lived experience. How does this differ from a peer counselor, or maybe what you do in your work? I imagine it might be the power differential in the two positions, or maybe it's still a more informed with a lived experience. So I think really thoughts on sort of what you're finding in your work. How is it an addiction counselor with lived experience?
Many have lived experience. How does this differ from a peer counselor? Many the power and differential the two positions, maybe still a more informed treatment provider with the lived experience. Thoughts on that? I mean, I mean, peer counselor. I don't know if there was a type of formal training. Many have lived experience. Substance use. Sorry, substance use. SUDP. Substance. Sorry.
Yeah, that's our license. Oh, Karen, you're there. Do you
Yeah,
I don't know the term.
I was just wondering, I think when we've worked with peer counselors, a lot of our addiction counselors or counselors for substance use disorders, a lot of them have lived experiences, but there's also a power difference, right? Because we may be reporting to the court or other referents. And then as far as being a peer counselor, I think, you know, the threshold is potentially less for that. But overall, I think, you know, someone who's working in the field with a license with lived experience is probably still a good thing.
What is SUDP? Sorry, I've never.
That's okay. That's a substance use disorder professional is
Oh.
Yeah.
Yeah, so I mean, I think, I mean, even in the terminology with like peer support, I think is like very, very, you know, definitely a reduction in power, but substance use disorder is very, to me, is a little bit more mental healthy, and probably looking at it like from a disease model, whereas many of us look at from a public health, and perhaps like with the peer counseling, it might be more needs based, and it's not necessarily a disordered type of. That's how I read into it, but we don't really. I'm trying to think of the equivalent. It's what licensed in Washington State. Ah, okay. Okay. Got it. So it is a licensed, yeah. So you're almost like accredited as like if you're disordered, if you take on the disordered piece. To not self-disclose. Oh, it's a professional license. Sorry, I'm reading these. This is very interesting. It's very interesting to me. I didn't know it was like in this. I didn't. Yeah, I'm learning. This is.
Yeah, I think what's important, and I think would be worth a bit more discussion, and we've been talking about this on the side. I think it's worth staying in this discussion format for the time we have, if that's okay with folks. Is I would really appreciate sort of your insights. There's a lot of what we have here around, you know, historically around addiction treatment. I trained in a methadone clinic 25 years ago. That's one way to do this work, often in the context of addiction and in the context of formal treatment programs. I think a lot of what you're talking about in your context is what we may more often call harm reduction. I don't see those things as distinct. I think there's a ton of overlap, but we often think of them as quite distinct, and the people as quite distinct, and the agency is quite distinct. So I think it's, and in some ways we have a very robust syringe service program network in Washington State, over 24 syringe exchanges that do amazing work. And we have some, you know, user-run unions and so on. But I don't think we have the same level of robustness that you all have. And I think, so there's the process that you all are using, which are really exciting to hear about, and which is really, really what I brought you for to hear about. But I think there's also this sort of capacity building for people who do use drugs, who have ways to join together and talk with each other and see their power and use their power. And I think that's a parallel piece. So it's wonderful to have the process for how you do this, but I think we also have some capacity building to do. And you can't do it from the top down. I can't do it as a university researcher. That's not my job. You don't want me to do that. That's not my role. I don't know how to do it. So there's also that piece about how do we really help, how can we be helpful in terms of providing supports that allow this sort of co-equal sharing of power? Because I really do think this does come down to power.
Absolutely.
And so I don't know if there's more you would say about maybe what it's like in your province, for people with lived experience, what types of organizations you have of people lived experience. And I'm sure there are many different types and people identify differently, but that might be helpful context as well, how those organizations exist, how that intersects with harm reduction, and how that also intersects harm reduction, what I think of in terms of reducing the immediate harms of infectious disease and overdose, and longer term for those who want to get their use, maybe they want a greater sense of control over it or move into something that they call recovery.
Yes.
How do those pieces all come together? That's a complex question.
Wow.
But I'm interested in how you see it.
Well, I mean, for now, now I have an idea because we have like our ICM teams here, which are like they work with substance use, and they're very intensive case management, and they have some peers that are in recovery. I want to point out that people who use drugs, the only time you're ever going to see an abstinent clause written into a job description, you know, are for people who use drugs, unless of course you're going into a dry camp or something, you know. That's the only time I've ever seen, but it's that's in general for everyone, not just a person who has a history of being disordered, and so, and knowing the cost of disclosure. So when I talk about the cost of disclosure, of course, is that stigma and discrimination if you come out about your substance use, and that it's somewhat relatively safe if you're abstinent and you come out somewhat. It can still be, you know, kind of like waiting for the shoe to drop, and you have these arbitrary numbers attached to whether or not you're employable. So we have a group of people, and they are abstinent, and they are working in the quite often in the treatment field, or, you know, getting people into a treatment program. Whereas with harm reduction, again, I look at that is a mental health substance. MHSU is kind of what it's called when you break it down into a health authority work. You've got your mental health and substance use part of the health authority, right? And then you have your populations and public health, which often hold the harm reduction piece. So your MHSU deals with treatment and recovery, and whatever that means. And then populations public health deals with overall people's health in general, which means not everybody who uses drugs is disordered, and not everyone who uses drugs is going to have the same amount of harms as others. I do think that the harms are very much not so much around the relationship with the drug, but again, that systemic pieces of harms of the criminality piece and such. So that's how I see, but how I see it is, I see harm reduction is on that continuum, and it's very much a part of, I mean, for some people, abstinence is harm reduction. For some, if they feel that they can't use substances in a way that's not harmful to self, you know, and again, that's for someone to self-assess and work with folks. But I mean, I've been labeled, and as I said, like now that I've, you know, I had 8 years abstinence. I mean, so I could get my daughter back, you know, is really what it came to, because I really enjoyed using heroin, and sadly, it's, you know, we don't find very much of it. But that, again, I had this disordered piece from that part of, if I was working with someone who, as I look at this, that's an SUDP, I think that having conversations around substances would have a very, very, you know, an end goal of recovery or abstinence, right? And whereas in my harm reduction or organized groups, it's either we don't really care where you're at, not that we don't care, but that to us, that's not as much as important as that you're getting your needs met and having equitable access and being treated with respect and dignity, and that there weren't horrific harms being done from a system based on drug policy. So that would be, to me, like this kind of difference, whereas I don't see a lot of conversation around those harms through our addiction peer teams that are out there, that they are not looking at that, and they're looking at the person to be, you know, basically responsible for their harms.
That's awesome. And I see we have a question, which I'll come back to in a minute. And Erica, I just want to share with you and give some context for folks on the call that you make a very important point about not all use is disordered or a person wants to stop. And to that point, I'll mention two things. One is, the psychiatric diagnosis, right, is substance use disorder. What I think is more meaningful is that emphasis on disorder or chaos. And that's often what people want to escape, is the chaos, not necessarily the substance use. And to that point, what we have learned from asking people who are using mostly methamphetamine and heroin at our syringe exchanges across the state is that about 80% of opioid users want to say they want to stop or reduce their use, but only half of primary methamphetamine users say they want to stop or reduce their use. There are different substances, there are different circumstances of use, there's different benefits and harms. And so I think, to your point, we want to provide an off-ramp for people who want an off-ramp as a beautiful dog. And we also want to, keep people safe in the meantime who are continuing to use and don't want to stop their use, and trying to figure out how do we also provide those. And those are not in opposition.
We're there too.
What's that, Erica?
I said we're there too. Yes. Yeah. I think a lot of people think that if you're involved in harm reduction that you're anti-abstinent, and it's like, I'm pro-choice, but it doesn't mean I'm anti-life. And so it's one of these things that I think we have to keep in mind. It's not a.
Great. Dan, did you have a question or comment you wanted to put into the conversation?
Well, I'm going to say I am a peer support specialist. I took the original CPC training about 5 years ago. I got certified, and I didn't get a job in the field because they didn't pay what I wanted, but I volunteered. I have an income, so I'm not really too worried about that. And I found that if I was 100% honest up front, there was no such thing as a power struggle between me or somebody who had a 4 or even a 6-year degree. Once they realized that I was being honest, they got honest. And there was no power struggle. I get called in to, in many cases, it turns out to be language interpretation. A lot of problems can be solved just by the simple act of listening and defining terms between the higher educated, and sometimes the higher educated individual is the one out there using, or with the mental health issue. But there is still a gap in between. And even those individuals that come in like I am and then get their licenses, they start stepping up on what's called ethics and boundaries. Now, I have a certain level of ethics and boundaries that I must follow, and everybody has to follow those same ones. But I can share more of my story than someone who is a licensed a counselor.
Hey, Dan,
in the recovery field.
Dan, do you mind giving an example or two of like a terminology that gets confused a lot and what different perspectives on it are? That would be interesting to hear.
Okay, you said harm reduction. Harm reduction, what does that mean to you? Some people means I stop hurting myself. And some people means I slowly learn how to stop hurting myself day by day until I get to the point where I'm no longer hurting myself, but helping myself. Some people say abstinence. What does that mean to you? Some people think, well, I stopped using cocaine. You know what it meant to me? It meant I stopped using all the psychedelic drugs I was on, all the prescription drugs I was on. I quit smoking. I quit drinking coffee. That's what it meant to me. Each individual has their own definition for a term. And that's where communications get messed up. Because you think it means one thing, they think it means another. They say one thing, and you're hearing something completely different until you learn to understand what those terms mean to the individual.
That's perfect. And I totally agree with you on that, Dan. The language thing is a huge thing and a great way to listen and join and understand from another person's perspective what's going on, because when we're assuming, it doesn't go well, right? I want to share a question from my colleague, Emily Hirio. This is for Tracy and Erica, if you're still there. I know that Erica was doing our harm reduction by pulling over to the side of the road, which I appreciate. And Tracy, when you do answer, your sound was a little tough, so make sure you come in real close, please. The question is, in your roles, what have been some of the best experiences you have had working with researchers, governmental public health, and other bureaucratic institutions? And what are the worst? So what's kind of been the best and the worst, and what made them that way? Why? Are you able to answer that? Are you there, Tracy? Oh, I see Tracy's getting her phone figured out. Eric, are you around still? Oh.
I'm here. I'm sorry. I had to retrieve my dog. Decided to run after somebody in the hallway. Can you repeat the question, please? I'm sorry.
Yeah, so Tracy, the question is basically, what are the best and the worst of working with us bureaucrats? Public health and researchers. What's gone well, what hasn't, and why?
I find working with them isn't bad at all. It's just once in a while you get the odd one that thinks there's a stigma there, right? And so they tend to talk down to you, or because I advocate as well for I live in a place that is supportive housing, and 90% of the people in here are from our first 10 cities. Okay, 90%, that's pretty good. But even the people that run the place, when I've gone in to advocate, I've actually taken someone else with me now because they've tried to speak down to me, and that's not it. Okay, I may be a tenant here, but I'm an advocate, and you talk to me equally. So that's my big issue with people that are Democrats, whatever. They just sometimes, most of them are pretty good. I'm a bridge, right? I use myself as a bridge between two worlds. I call it two worlds because we speak differently. The way I talk to you guys is one way, but when I'm out on the street, my language is a little different, right? It's not the same. So I try to be a bridge between so-called normal people and the people of the streets. And I never say homeless anymore. I came up with a new term, and I use it because it's more dignified. They have a home. The home is their streets, your streets. Therefore, they are your street population. So that's what I use instead of homeless or addict, the street population. But I enjoy doing what I do, and the videos that we've come up with, it's helped a lot to reduce some of the stigma, because when people get like that with me, I usually direct them to YouTube and watch these videos, you know? Gives them more of a better idea by seeing stuff, not just hearing it from you, right? I enjoy what I do. I don't have to come across too much trouble. Like I said, just the odd times somebody tries to.
Okay, great. Thank you.
Thank you.
Hey, Bernie, what about you? What have you learned as a researcher?
Oh my gosh. Wow. I'm just trying to pick out one or two things. I think it's about flexibility and, you know, being responsive to what the needs are. I'll just give a quick example. The overdose prevention sites, when they opened, I had worked with the drug user organization here for a long time, and they called me and they said, Bernie, this, like, there's, you know, everybody else can get counseling through their employee assistance program, or, you know, in the media, the ambulance people are the first responders. But you know what? We're actually doing the first response here in the overdose prevention sites, and we're working really hard. Our people don't want to see their friends and family die. And they said to me, like, where's our supports? This doesn't, you know, this is like too hard. And so I actually called up Jane and said, Jane, like, what are we going to do about this? And that's really where the P2P project, where we partnered together on it and came together and brought the organizations together. So that was flexibility. And then I guess for me, the second thing is relationship, you know, and building those relationships with your colleagues in the community. So that's for me as an academic researcher.
Great, thank you. And I'll share personally that I definitely didn't really get training as an academic researcher in that. Thankfully, I also have a social work background that gave me some introduction to that. You know, one thing before we go to a couple more questions, I think, Bernie, would be helpful if you or Tracy want to explain a bit. There's some language and some activities that you all do in British Columbia that I know were newer to me in the last few years. And if you don't mind explaining a couple of things. Tracy talked about the idea of peer witnessing, which I think is a very important notion, about overdose prevention sites, and also this phrase safe supply. So peer witnessing, overdose prevention sites, safe supply. Those are three things. The language is not as common down here in Washington State, and I was wondering if you could maybe just describe, Tracy, if you don't mind maybe describing some of that for us, please. Thank you very much. So, and I'm going to write a note here just so folks know what Tracy is really describing. The peer witnessing is essentially what it sounds like, that you're with the person while they're using. You're not injecting them, but you're with them and being supportive and watching them, making sure that they're not overdosing and being available to them. Tracy, your sound's a little bit tough still, unfortunately. So I'm going to ask if Bernie, if you don't mind describing those overdose prevention sites and also that language around safe supply. I think it just might be a little easier to hear.
Thank you.
Thanks, Tracy.
Thanks. So the overdose prevention sites, that model was really people with lived experience setting up initially pop-ups so that people would not be using alone. So our Take Home Naloxone program, Jane and others started it in about 2012. So there was, you know, naloxone was really available. You don't need a prescription. And so when you put those two things together, don't use alone, and make sure that you have someone observing you and you have naloxone, and then putting that into a space. And so the picture that I showed you was a picture of one of the overdose prevention sites. I've forgotten the number across British Columbia right now of how many there are. Zara's on the call. She might be able to put it in the text box because I'm just blanking on the number of them. So they're not there. They might be in a building where, you know, for example, one I know of was in a shelter, and it was in a reclaimed space in a shelter. So just, they're usually smaller, 3 or 4 spaces. They might be a pop-up, they might be a tent. And there are a few that accommodate inhalation as well as injection. So it's just really that act of someone observing you while you're using. So that's overdose prevention sites. And then the other term you asked about was safe supply. So there's a lot of different ideas, and there's a lot of papers out there of safe supply. But I think the way that it's happening right now in BC is that their physicians are prescribing a broad range of alternatives to illicit drugs. So the risk mitigation guidance, it's being rolled out at the beginning of COVID, people gaining access to Dilaudid through their prescriber, as well as benzos, a few other things as well. But I just, that's a very limited version probably of safe supply, you know, being more broadly defined as people having access to the substances that they need, require, you know, in a safe way. I can certainly send a few references from like Canadian Association of People Who Use Drugs and a few others who have a nice broad kind of clear definition of safe supply.
Perfect, thank you. And for folks also who are sort of newer to the work that we're doing at the Alcohol and Drug Abuse Institute out of this Transforming Our Communities work, this is some of the information we'll be continuing to share. There's a lot of research and evidence-based work and practices that are happening in Canada that are not happening here, in which people have interest in. Some are legal in the United States at this point, some are not. But there are more things that can be done, that is for sure, both on the currently allowable side of things and not. And I think it's important for people to be aware. I think what's interesting for me when I have the opportunity to be in British Columbia is the variety of options. It isn't that there's just one thing and that's it. There are multiple different options run by multiple different organizations and multiple different communities. And that makes good sense. So I want to come back to two things. My colleague Mandy Owens had a question, and my friend Brad wanted to share something as well from the Seattle area. So Mandy's question is about thinking about balancing the burden on our community partners with continuity on projects. What are the thoughts on working with a larger group of community partners versus 2 or 3 individual partners. So I think that sort of, how do you manage the scope of this work is maybe a simpler way to say that.
Thanks, Caleb. I feel like that might be a bit of a question for me. Yeah, that is a beautiful, it's a critical question. And the amount of kind of work and energy it takes on everybody's part is huge, because it is built around building those relationships and finding ways to work together. And I think, you know, I'm going to sort of point to Jane and the way that she works, I think, you know, is she develops a few partnerships, and then you work with them through project to project. To some degree, I do that. I have a very large, I mean, she has a large group too, but I have a very large group of community partners. So, because really my program of research is bringing together community members who are part of drug user organizations or peer networks, and with service providers and policymakers, and then us as researcher. So you just can't get away from a larger group. But my advice is, when you have those large groups, is to do something like what we did in the safety, the primary care project, where we created a core team that was just the academic researchers and the people with lived and living experience, with the other partners as advisors to us, or, you know, being involved in knowledge translation, or because their role really is to translate the evidence and the advocacy. They don't need to be involved in the research the way that people, you know, Erica spoke to it really well, like about, you know, the important role of being involved throughout it, experience.
And what was interesting, I encourage people to look at the CoLab webpage, which with the link for that, which we can put up here in just a moment, is in the announcement for this meeting. They have a really nice logic model. I know that's a very nerdy thing to say, that you have a nice logic model, but you do, and it's very thoughtful. And what's interesting to me is that it seems like really the main goals of the logic model for your CoLab work are oriented towards, and I think Erica, I think said this earlier, what we have expertise in is we have the ability to help find and disseminate accurate information so that people who use substances can make informed decisions. Because so many of the substances are illicit, they're literally in like the worst behavioral economic scenario ever, which is you have no good information to make your decisions on. And you also don't have those tools. So if you look at the logic model, it really is aimed towards, as I saw it, really about generating useful information for your community and for people who use substances. There's a separate thing, I'm guessing you might have another track that isn't there, that is, and by the way, how do we do the research to facilitate that? But that's sort of, as you said, that's our work to do over here in partnership, but the real goal is to be of service to the community first and foremost, if I hear you. And so a couple of things I'll share. Lisa Ray Thomas just posted the link to your webpage. I also posted the link to our webpage, which is around the activities we're just starting to launch this year in Washington State. And then I do want to come back. I think Mr. Brad Finegood from Public Health Seattle King County wanted to share something. Mr. Finegood?
Thanks, Caleb. Appreciate it. Hey, and thank you to our folks from Vancouver who presented today. I was so excited that I didn't even realize it, that when I got dressed this morning, I had on my Crosstown Clinic. So I just realized that was the case. But I just wanted to first of all, extend our thanks and for bringing your presence and your knowledge and everything here today with us. The other thing I just wanted to say to my King County colleagues who attended the Transforming Our Communities conference that we had a month or two ago and attended the King County breakout session, you should have gotten an email from me yesterday about our Just Access to Health meeting that we have tomorrow. And I would really just encourage and welcome any of you who are interested in continuing the work that we've been doing around improving access and care for people who are currently using substances, and you know, to be able to do that work. We're in the process of sort of finalizing recommendations, and we would love people's help on dissemination and your input and all of that type of stuff. Also informed by people who are using drugs in that community. So I'm super appreciative. Thank you. And hopefully for those of you in King County, you'll join us tomorrow at that meeting. So thank you. Thanks for the time. I appreciate it.
Great, thank you. I think sort of in the spirit of being flexible, I think we'll wrap us up. I definitely agree with Bernie. As academics, we have this illusion of control, and you pretty much got to get over it. I don't know what else to say other than that. And so I really want to thank Tracy and Erica for sharing their expertise today, and obviously just your incredible passion and skill in the work that you do. So I really appreciate that. And also thank Bernie for helping facilitate and coordinate this. So again, this is part of our conversation that we're really just getting going here in Washington State. And I'm just really appreciative of you all for joining us. So I think with that, I'm going to say thank you and good afternoon, and take very good care of yourselves and your loved ones. And we will see you all again soon. So thank you and goodbye.
Thank you very much.
Thank you. Bye.
Thank you, everyone.